Welcome to the Older Adult Live podcast. And I am Shelby Blankenship. I am one of your TAs. You usually will see me in L2, but also at some of your live courses. And I'm so excited to be here with you. So we are going to be talking about Baker's cysts. This is something that the extremity division kind of mentioned in a awesome Instagram post back in August. And I actually had a patient today that came in with one if you have someone who walks in with these symptoms. So just to kind of give a recap of what a Baker's cyst is, if you're not familiar with, it's a popliteal cyst. So it's on the back side of your knee. It's usually a fluid-filled sac that can be behind the knee, and it can be swollen, pretty painful for some people, especially to palpation. And for the patient that I had, she also had some palpation, not only at that site, but down into her calf. And so that can be a little bit problematic, especially when it comes to walking. She really was limited in total knee extension primarily, but also total knee flexion. And that can be really limiting when her job is a dog walker. And so we want to really make sure that she has the capacity to walk not only to the endurance level and capacity that she needs, but to the mechanics that she needs, so she doesn't have other things that kind of pop up because she's able or having to walk in kind of a funky manner. As far as Baker's cysts go in the older adult population, the people that tend to have these, especially with older adults, we tend to see these about 26% of folks, but if they have a history of chronic knee issues, especially with pain, arthritis, meniscul injuries can be a part of it, that can go more upwards into 40%. And so it's something to kind of keep in mind, especially if you're seeing folks for a lot of knee issues or just want to kind of be more proactive about trying to limit something like this from popping up in the future. So like we talked about before, symptoms that you're going to be seeing: posterior knee pain, but especially some swelling there. And that's something to kind of keep in mind. Now, as far as like objective measurements that we're looking at, definitely looking at knee flexion, range of motion, and extension. But we also want to be looking at what their strength level is in both of those directions, but also want to look at the hip and the ankle. We don't want to just kind of silo just the knee. When we're looking at it, we want to look at the different attributes above and below that joint to make sure there's nothing else to the symptoms, because usually these symptoms don't just come out of nowhere. It's usually kind of like a building effect. And so we want to make sure that, are their mechanics funky, or have they had this history of arthritis and it's actually coming from like glute med weakness or something like that. So definitely look at those attributes as well, because we're not just treating like the cyst. Like there's nothing I can do to necessarily make that cyst like smaller. Obviously they can do surgical intervention where they aspirate it, but that's something like we don't want to have to do if we don't have to. And so we want to treat like the actual knee, and especially if we have some contributing factors from the hip or the ankle. So those are the three attributes we looked at. We looked at strength of those, range of motion of both of those as well, to kind of see if there was any opportunities there to maximize, especially when walking is such a big part of her life and she's wanting to get back into strength training. So once we did that, what we did for her home exercise program, she has the tendency to be a caretaker at her home. So she is a very, very busy woman. So I tried to limit her HEP to just 6 minutes. And the biggest thing here is I'm trying to look for consistency and quality of her HEP, but also trying to sprinkle in those factors of optimizing sleep, because that's something she's not doing super great right now. I'm also looking at trying to optimize her nutrition. Right now, she's only eating 2 meals a day and is really limited on the amount of protein that we're getting. So especially when we think about like arthritis and the tendency for it to be a little bit of a metabolic syndrome where people are not getting good regulation on blood sugars, there's lots of inflammation. We really want to make sure that we're optimizing that protein intake to not only help regulate blood sugars a little bit better, but also maximize tissue healing, maximize muscle mass. And if we do that, that usually tends to make our folks with arthritis, but especially like Baker's cysts, things like that, we want to kind of minimize their symptoms so they can have a higher quality of life, ultimately optimizing the ecosystem that that human is, keep them as robust as possible. As far as the exercises we did, the first one we did was I had her lay supine with her knees over a bolster, had a strap over her foot. We did a short arc quad and then a little bit extra extension at that knee using that strap, held that for a couple seconds and then went back down. We did that for 1 minute. Obviously, the biggest thing here is trying to modulate pain. And we try to optimize like no more than like a 4 to 5 out of 10, especially if those tissues are a little bit more on the irritable side. I want to make sure that we're tapping into optimizing that blood pump, but not upregulating that nervous system. So that was the first exercise. The second exercise is we went into the same variation of that, but more of a long arc quad situation. So she's sitting on the side of the bed, same thing, strap is over the ball of the foot. She actively extends as far as she can and then uses that strap to get a little bit extra so that we can maximize that full knee extension. The third exercise that we went into was doing a total knee extension using our pull-up bands, so the little bit more robust ones against the rig. I gave her an option to do that with like a door hinge, door attachment for home, but we did that also for a minute. So all of these are for a minute, going through it twice. The goal is to do that daily until the next time I see her, to kind of see if we can optimize that knee extension as much as we could. Because at the time of her eval, she was at 12 degrees away from neutral. So we had a lot of room for improvement there. And especially because that's going to mess up her gait mechanics a little bit. So as far as what next steps would I do? The biggest thing I want to do is maximize her knee extension first. If anybody has used or been utilized seeing total knee folks, the biggest thing we want to get after early and often is total knee extension. And then we're going to kind of get after the flexion. If people are really struggling with total knee extension, it's going to make their gait mechanics super, super wonky. And so I want to get after that first. And especially since she's more in a flared up state, not only from a musculoskeletal standpoint, but like a nervous system, stress management standpoint, I'm going to try to see where we can start kind of low, get some buy-in, make sure that she's feeling like she's getting some results, but not absolutely killing herself yet. And then we're going to try to build. From here, my next steps would be from total knee extension. I would like to try to do Spanish squats in the future. Maybe that's next section, maybe that's in the future sessions, but that's one of my favorites for total knee extension because it's a functional movement, but adding into that quad component. The other ones I really like doing is backwards walking, especially, again, going after that total knee extension. I have an option where I can do that both with bands, but I also have a sled that will allow me to go forward and backwards. So that will be a great option for her. And then the couple other ones that we'll add in is definitely some deadlifts, but if we can make it a single leg RDL in the future, one, to optimize like that stability of that joint, but also really get those quads, hamstrings simultaneously firing, see if we can get some more optimization of those tissues so that ultimately we can help prevent any further opportunities for a Baker cyst environment to be, but also hopefully if there's any history of arthritis or those kinds of things, we can calm those symptoms down and really optimize the tissues surrounding the knee. So just to kind of recap what we talked about today. So we went over Baker cyst, what its symptoms are, what some things that we can kind of think about as like who's coming into my clinic and making sure that we're kind of screening for this, if this is something that we're kind of watchful for, especially if they're having that posterior knee pain. We also want to make sure that we're treating the knee and not just the cyst. I thought the extremity division did an amazing job of really emphasizing this in their post that they did back in August, if you want to check that out. And then obviously we're trying to maximize range of motion and strength, optimize functional movements as well. But those are the first two tiers that we want to start with to make sure we're getting really nice mechanics, especially when gait tends to be a big culprit for these folks. And we want to make sure that they're getting that full knee extension. So hopefully that was helpful for you. I'm excited to see how this lady does the next time I see her, and hopefully you'll get an update soon. As far as next steps for what classes we have coming up, December 6th, we'll be in Kingston, Ontario with Christina for our next Older Adult Live. Then we will also have another one December 20th in Miami, Florida. And then L1 will be starting back January 14th. And L2 will be February 9th. So if we don't see you at any of those, hopefully you will catch you at the next one. And we really appreciate y'all. Have a great Thanksgiving week and enjoy time.